Good morning and welcome to the Caregiver Teleconnection. My name is Glenda Rogers and I'm going to be your facilitator for the session today with Dr. Nestor Praderio. He's going to be talking about understanding dementia. And before he gets started, let me just tell you a little bit about him. Dr. Praderio was born and raised in Argentina. He is a graduate of the University of La Plata School of Medicine and completed his residency in psychiatry at the Yale University affiliated program of Connecticut Valley Hospital in Middletown, Connecticut. His special interest is focused on geriatric psychiatry. He is a consultant of many nursing centers and assisted living units in South Texas. He is also the founder and president of Face to Face, which is a nonprofit organization and Alzheimer's support group. All of his time is dedicated to this organization, is volunteered, and it includes monthly meetings in which he speaks to family, caregivers, and clinicians, annual face-to-face festival, where we'll have more information at the end of the session, and a yearly Coastal Bend Walk for Memory. Dr. Praderio, thank you so much for being with us today.
Thank you, Glenda. Thank you for your introduction. And happy to be here. And at the same time, I extend my gratitude to Minerva. This is always ready to help us. We are here in the middle of the year. Time flies. And I decided we will do a little refreshment in what is going on with dementia in general, because every time that I have a meeting, every time that I do a presentation, there are a ton of questions about dementia, the signs and symptoms of the disease. And I say, well, but let's go and do a review. Keep in mind, dementia is a neurological disorder, it's an impairment of memory. The memory that is impaired is the short-term memory. It's the memory that occurred just a minute ago, 40 seconds ago, 3 minutes, or half an hour. It's not the memory of the past or time when we were in high school, graduation, baptism. No, it's just the short-term memory that specifically interfere with the mechanism and the ability of the individual to think in the form that they were previously put together to think. Therefore, from the beginning, create a little of concern for the individual, but as little it deteriorate, create more fears, anguish, poor understanding, not recognizing exclusively what is going on with them, and having a problem. The dementia have as a risk factor, the most common one is to age. Therefore, the older that we are in our population is the increase of probability to develop. But it's not a normal part of aging. We cannot say you grow old and you will become demented. No, but age is one of the factors that is an impact in the human beings. Now, how we define the dementia? You hear me talking about memory deficit. Therefore, it's the development of multiple cognitive deficit. There is memory impairment, at least one of the following, and we call the 3A, and is aphasia, apraxia, and nausea, and disturbance of executive function. For aphasia, the difficulties are the following. From the initial time, individuals have difficulties in having an expressive aphasia, mean they have what we call commonly here on the office a word-finding difficulties. They want to express something, they don't remember the appropriate word, and suddenly they become very anxious, partially agitated. Sometimes we decide to guess for them, make the situation worse. That is an expressive aphasia. And on the contrary, they have difficulties comprehending what we share with them. Therefore, they have receptive aphasia. Therefore, aphasia can be, I cannot tell you everything that I am thinking. And on the other hand, you talk to me and I just grab 50% of what you say because the rest, I didn't get it, I didn't understand. Apraxia, there are difficulties with the small neurological movement. They have difficulties winding the watch. They have difficulties in accommodating the timing in a microwave oven. They have difficulties with small neurological movement. And with nausea, difficulties in naming things. Therefore, you show this pen and they say, well, what is the name? Oh, I have it with me. It's something that you used to write, but they cannot remember the specific name. And when we refer to executive function, are the functions that inhibit any inappropriate response and protect the selected memory of our learning, the superego of our society. Es decir, how we grew up, the way that we grew up, what is appropriate, what is inappropriate to be sharing, and then the way that we act in our free society. Well, dementia is a package of clusters of symptoms that may appear in one or in another form, but they are marked by the chronicity of the illness. And this is an illness that progresses. We cannot see an initial dementia today and believe this is going to improve by the end of the year. That's not true. It's decline, progressively decay, and increased symptoms or the acuity of the symptom. When we start naming symptoms, like I said before, the memory loss is affecting the everyday living. But like I shared with you before, it's the short memory loss. Therefore, the lack of memory of what we just did 2 minutes ago impact very clear inability to function in a normal world because they don't let you to continue with your conversation, to put things together, and to participate with someone else. Therefore, it's distracting, it's confusing, and it's leaving you honestly weak in front of others to converse. Therefore, this first symptom is the one who calls the attention of the individual suffering the memory loss. This first symptom is the one that makes them to pause for a while and not to be as participative as before in order not to expose any problem that they may have. This first symptom is the one who all together create a remarkable effect for denial. I am okay. I am okay. I don't have any problem. I don't know what you are talking about, my memory. I don't know why. My memory is better than yours. And therefore, this is the part that initiates the process. This is the part that creates resistance. There are degrees of poor judgment, and the degrees of poor judgment can associated with some difficulties of executive function, such as poor planning and such as poor rational intervention, and which one with poor judgment and with no ability to make rational intervention, make everything complex, the capacity to make a decision is being impaired. There are disorientation at the close to the end of the initial stage of the disease. Some disorientation takes place, and at the beginning is play inside the home. They go from one room to another, and then when they are there, they don't know exactly what they were doing there. They have difficulties if they wake up during the night and they use the bathroom, and then in the return to the bedroom, they get lost in the living room or other places. Those are the first message of an incoming disorientation. Then later on is more expressed, for example, by driving and getting lost. At the beginning of the process, it starts changing the affect, the mood, the behaviors, and the personality. A high number of individuals that develop dementia carry together symptoms of depression, not necessarily a major depression episode, but yes, a depressive symptom that interfere in life, increase the level of anxiety, create some moodiness, and impact very much in personality, becoming a little more isolated. They are sometimes more complaining, sometimes become a little more resistant in activities that they were doing well before. And some of them show such a lack of interest in usual activities, in activities that they were doing before. They don't read the newspapers anymore. They don't want to follow the news in the iPad or the laptop. They don't want to participate in things that they were doing, and they partially isolate in this process because they have some sadness and depression. Here we continue with the impact in the ability to communicate. And they use unusual word to refer to familiar object. The anomia is presenting. They have difficulties to name it. This is a mix of an expressive affection presenting the difficulty. Therefore, they refer to the object in whatever word they want to invent. And the short-term memory is impacting without retention up to the point that they ask questions, constantly questions. This is sometimes becoming a little disturbing for caregivers and present some difficulty. But you know, the questions occur, and I would like you paying attention to the question occur because there is no retention. There is I answer. For example, I drive with my mother to the doctor, and she said, "Where are we going?" And I said, "Mom, we are going to your doctor." And a minute later, she said, "Where are we going?" And well, in what direction are we going? And will be interesting if we have little stickers and you write down. If you are already preparing your mind to this situation before leaving home, you can write in one sticker, "We are going to the doctor." And when your mother asks you the first time, you put a sticker on there on the glove compartment. And when your mother asks the second time, you say, "Mom, read there." Therefore, she will read and she will say, "Oh, we are going to the doctor." "Yes, ma'am." And that's visual channel is better than the auditory channel of answering and answering and answering constantly. This is one of the ways that you can manage this difficulty. But she is not asking because she wants to disturb you. She is asking because she never was able to deposit in her brain the previous answer. The previous answer was gone. You said, but it's gone. And then they ask again, and it's gone. And they cannot retrieve information. They lose interest in normal daily tasks. And I was sharing with you, I think some of them are what we were doing in a daily basis. And they become a little more distant. And sometimes, with the loss of executive function, they behave like a young kid that they don't have much sensitivity in what they said to other people or how they refer to other people. Remember that we say, well, they speak without filter. Well, that's what's happening here. The lack of executive function, sometimes they make her no caring about other people's feelings and to sound more rude and direct. They have difficulties with judgment and specifically difficulties in decision making. The decision making process become very simple, very primitive. Even individuals with career and high level of education, suddenly they turn in just more reactive than thinkers, and they get themselves in trouble with making pay bills and writing checks and managing responsibility, financial responsibility, handling different situations because their decision making lack rational, they are less capable, and they lack some judgment. There is no overthinking, evaluating consequence in what is going on. At the second stage of the disease is when we start having some hallucination or experiencing delusion or paranoia. The hallucinations in general are more visual than auditory and occur a little more in some dementias. For example, Lewy body dementia and Parkinson dementia. Then those may create other complications because delusions in general come associated with a more aggressive, possible violent behavior, it has to be monitored closely and medicated if it's necessary. They sometimes respond to a low dose of an antipsychotic medication in order to correct the disbelief or the lack of contact with reality provoked by the delusional process. They are losing balance and problem with movement. Sometimes individuals move around with a little more the rigidity. We need to be careful to rule out Parkinson's disease. This might be an associated event, but we need to pay attention. They have some problem with balance and they fell frequently. We need to take it into consideration and see what happened with them. They have difficulties performing familiar tasks. The most common for us, for men, is we start getting confused in driving and getting confused in some mechanical movement. I have a patient that he was a caregiver suffering in own self dementia. Therefore, he cared for his bilateral amputee diabetic wife. And his dementia was approaching the moderate stage. He was taking care of everything. Frequently, he would share with me how busy he was. Therefore, he took the car and went to do shoppings to the local supermarket. And he take his listing because he need to write down. If not, he will forget. And come back with all of his shopping and stop in front of the garage and start beeping the horn. And he beeped the horn and wait for a little while. And he beeped the horn again. Well, finally, the neighbor came outside and said, "Bob, what are you doing? Why are you beeping the horn? You know your wife won't come here. She's on the wheelchair." And he said, "I'm not beeping the horn." And he said, "Yes, you have been beeping the horn." He said, "No, I was just trying to open the garage door." Therefore, he confused the garage opener with the horn. And he was expecting the beeping the horn, the garage will open. In those level of confusion, that's not a delusion. It's a level of disorganized confusion create a little more difficulties and create more problems. And they have problems with thinking after. What is the etiology of dementia? Well, we can say that we have reasons and we can divide it into reversible reasons and irreversible reasons. And when we say reversible, it's a process of dementia or cognitive deficit similar to dementia is presented, but we make appropriate diagnosis, and the diagnosis is being corrected, and the individual correct the cognitive deficit. Therefore, in another word, I has been demented today, but they cure me tomorrow, I am okay. Between all of those, we have many related with medical problems. and specifically polypharmacy. There are individuals that take so much medication that they become confused, disorganized, with very low attention and concentration. Something happens if they mix a little with alcohol. There is an old saying of individuals with depression. They were presenting, and they were presenting with cognitive deficit. Therefore, they were always alert of no confusing this with dementia. Some surgical brain lesion, the normal pressure hydrocephalus present with symptoms of dementia, but they shunted the brain, they remove the fluid, and they recover, and the person do very well. There are some dementia presentation product of subdural hematoma. After correction, people evolve and become normal. Metabolic disorder like a hypothyroidism, hypoparathyroidism. Vitamin B12 is a common one, specifically in countries in which the nutrition and the consumption of vitamin B12 is poor. Neurosyphilis and HIV illness. Those are the reversible ones. Now, irreversible reasons are dementia associated with an impact on the brain is damaged, and there is no ability to recover. And the most common dementia in the United States is Alzheimer's disease. Approximately 62 to 63% of the dementia are Alzheimer's disease. Let's use some time to talk about type of dementia. I share with you that the most common one is Alzheimer's disease, is followed by vascular dementia, difficulties with circulation of blood on the brain, individuals who have previous cerebrovascular accident, individuals that have previous stroke, and difficulties in memorizing, and those are the vascular dementia. Frontotemporal dementia have a poor prognosis, is more rapid in the development. Sometimes is a little more agitated than other dementia. Parkinson dementia and Lewy body proximately provoking symptoms of certain degree of similarity with some muscle, body, joint difficulties, and both of them partial agitation, poor night sleep, and with poor response to psychotropic medication. There are mixed dementia. Mixed dementia are cases of Alzheimer's with vascular. There's alcohol-related dementia, HIV, multiple sclerosis. There is a dementia called limbic predominant age-related encephalopathy. It is similar to the brain disorder impacting memory and thinking. However, the underlying cause are partially different. We have before, when we talk about reversible, the normal pressure hydrocephalus is an abnormal build-up of cerebrospinal fluid on the brain. We have the Creutzfeldt-Jakob disease, is the cow disease that was reported initially in England, and then we learn about this. It's a brain disorder is contagious. It's very rapid in the progression. I have two cases here in Corpus Christi, and both of them, between diagnosis to the time of death, took approximately 1 year and a half. Huntington disease, inherited progressive brain disease, and chronic traumatic encephalopathy caused by repeated traumas of the brain. This is the disorder from soccer and football players. Associated medical conditions that appear with dementia. A common one, and we already talked, is anxiety, stress, and depression. Very common, those three, because it start with anxiety of not knowing exactly what was going on with you at the moment of lacking your memory and not having a better understanding. Then you enter in a process of more loneliness, separation, isolation, and depression take place. Delirium is a presentation in which one individuals present with alteration of the concentration and the attention, with some associated symptoms of psychosis, delusions, or hallucination. Delirium may be caused by multiple causes. We have delirium caused by infection, specifically UTI or pneumonias. We have delirium by dehydration. We have delirium by fever. We have delirium by multiple use of medication at the same time, polypharmacy. Therefore, we need to be attentive because a presentation of a delirium is a call of attention that something else is provoking this, and that we need to act over the cause. There are head injuries associated with dementias occur, some of them just by the actual hitting of the head or falling. Might be association with tumor, vitamin deficient. Remember how important is the deficit of vitamin B12. And here, the polypharmacy decided to refer because elderly have comorbid situation in medical illness, therefore more medication are being used and they have more difficulties, as well as problem with thyroid, kidney, or liver problem. This is something that occurs. How we diagnose dementia? Well, we do a physical examination, laboratory work, because we want to be sure that we do blood work, and this is the time in which we evaluate liver function, thyroid function. We ask for vitamin level. We got a good interview with collection of medical history, family history, a medication review of everything that they are taking, a neurological examination if it's needed. You can do imaging studies with brain scan. Specifically, in Alzheimer's disease, is more to rule out any other condition than to specifically find a pattern of imaging that will help the diagnosis with CAT scan or MRI. You can always use PET scan and they confirm diagnosis. And we do a geropsychiatric evaluation, and we accommodate test result, report, imaging study, and end up with an impressive diagnosis in which one we sit then with families and caregivers and offer a conversation to constructively put all of this together to talk about a difficult prognosis because it's no carving stone. Every individual responds differently. And to initiate a treatment plan. This, like all of you know, until today and this present, we have difficulties in calling the treatment plan curative because it doesn't exist. But you can do a plan. This is pharmacological in some characteristic, using medication to at least treat underlying associated symptoms such as depression and psychosis, and to give some maintenance and quality of life, and non-pharmacologic approach to the patient. With this in mind, we are going to reach a conclusion. We always fight for early recognition of the disease. And sometimes sarcastically, people say, why you want early recognition? It doesn't have a cure. And honestly, it's because if you recognize in early stages, you set up a good treatment plan, you meet with a family or caregiver, you put a treatment plan in place, you can talk about what is coming ahead of this, and you improve the quality of life of the individual, and you help the family. Remember this when you are dedicated to this task, you have to target what is cognitive and non-cognitive deficit. Will be impossible for me to treat dementia disconnected from diabetes, COPD, or other comorbidities from medicine. This is deteriorating the condition of the patient. Therefore, we join hands with other specialties and trying to produce the best and offer to the patient. The comprehensive assessment and early treatment is really maximize the patient function, and it's good because the patient has a little longer time to enjoy their life, as well as the less caregiver burden, because caregivers have a very, very difficult participation in having to be providing service on a daily basis. We talk about pharmacologic and non-pharmacologic approach, and like always, future researchers like it to identify very early detection methods and disease-modifying treatment, because this will bring a light into the life of individuals suffering this very devastating disease. It's a silent disorder. This is coming slowly, it's robbing your life. With this, please, Glenda and Marianne, we are ready for questions. I enjoyed very much. I really thanks all of you. And thank you all of the participants. And I am free for questions.
All right, we have one from Karen, Dr. Praderio. Is Lewy body dementia a rapid form of dementia? She continues, family member has been diagnosed, so would like to be prepared as person is aware of the diagnosis and is currently fine at this time.
Lewy body dementia have a progression. This is a little more rapid compared to Alzheimer's dementia, specifically because have fluctuations between good and bad. The patients appear sometimes to be doing very well with a preserved rational, good level of participation. And few hours later, just few hours later, they change completely, they react extremely out of context, and they become violent and more aggressive because Lewy body dementia have those characteristics. It's more impulsive, more violent. And, I will say this, how, when we decide to tell the individual with the disease, well, I think you can share and accommodate the sharing according with the stage in which one the person is. I think with an initial stage of the disease, between the doctor and the family have to have an acceptable management to inform the person, regardless with the heavy amount of denial that you will be facing. And you don't argue. You don't try to destroy the walls of denial because you will decompensate the patient. You will create anxiety. You will create nervousness. It's better to work with a family united, understanding the disease than to go and hammering the patient until the patient will say yes. In stages moderate and more advanced, I think it's important if you want to share, but the patient type of memory retention is so poor that your information will stay with them for 20 seconds and then they won't remember anything. But what will you provoke with 20 seconds is a level of high anxiety and the possibility that they start acting up, not being able to communicate in any other form.
Thank you, Dr. Praderio.
Any
Ms.
other
Johnson.
question?
Yeah, oh yeah. Ms. Johnson, I see you have your hand up. Go ahead. There you are.
I have a question about just keep someone who has dementia, keeping them like engaged to a degree and keeping them like active. How do you have recommendations for that? Things that you can do to just keep them engaged, keep them active, keep them just doing things really, because I find that like my stepmother has dementia and I just find that it's a little, sometimes her attention is not focused on certain things, or she lacks a lot like interest sometimes. I'm just trying to understand just some options that are out there.
Well, participation in activity in dementia is very positive. It's more positive than any medication that I can give to you at this moment, because enhance life and add quality to them. Now, let me tell you, I think some parameters have to be put in place in order to have a level of participation in activity that is safe. Therefore, safety is the first thing. Is someone like to continue driving? We need to be sure this is driving appropriately. If mama say, well, I will love to cook and I cook 57 years, why you are taking me out of the kitchen? Therefore, you in general minimize cooking time, give things that are distract her, make her to take care of the veggies, make mama to peel potatoes. The sense of participation is there, minimizing the seriousness and bringing some safety into the picture. But please, participation is very, very important. Take into consideration this fall may occur. Therefore, we alert for those kind of things. But yes, it's okay with good supervision.
Mm. Thank you, Dr. Praderio. Carolyn asked, and I'm not sure I understand this, so we'll go through it. Does aphasia lead to Alzheimer's, and is aphasia treated with Alzheimer's drugs? I'm not familiar with aphasia. Do you know that?
What
Or is it
lead-
aphasia? It's spelled ALPHASIA. Carolyn, you may have to unmute and discuss this with us. There she
Hi,
goes.
can you hear me?
Yes, we can.
Yes, Carol.
Okay, so my husband, he's been diagnosed with the aphasia type of dementia, the language
Ah, okay.
type. So,
Perfect. Yes, it's not very common. I have one case disappear about 2 years ago. I diagnosed his hearing corpus, me and the neurologist. Yes, is in which one the center of the deficit beside memory is located at the language level. And in general, the behaviors are very similar. Some individuals, sometimes during the transcourse of the disease, become a little more agitated with more difficulties in expressing symptoms or expressing things and become a little more agitated.
And so, is aphasia treated with Alzheimer's drugs, Dr. Praderio?
Well, in general, we have Alzheimer's drugs. This we sometimes use in vascular dementia or in Parkinson dementia, as well as Lewy body dementia. Yes, what we attempt to do with language compromised dementia is to be sure that they are not extremely depressed or very agitated and to compensate with some medication.
Yeah, that makes sense. Maria would like to know, are there exercises to do for, let me read this again. Are there exercises for the dementia person that is in early dementia?
Well, excellent. A good nutrition and exercise are very interesting addendums to a good treatment plan. We always say green veggies is spinach, asparagus, lettuce, some mixed nuts is very important on the diet, fish with high amount of oxidant once or twice a week is important. And exercise, excellent. Take care in balancing diabetes, take care in balancing high blood pressure, and decrease consumption of alcohol and smoking.
So that's good for all of us though, Dr. Praderio, right?
You're right.
Karen, what are your thoughts on Prevagen over-the-counter medication?
That was a question. Okay.
Yeah.
Honestly, let me divide the question with two responses. Honestly, Prevagen present all of the study material to the FDA and was not approved for the use in dementia. But Prevagen continue on the market, and they are not advertising and telling you that Prevagen is identical to Exelon or Aricept, but they continue on the market. And a high number of my patients ask permission to take it, specifically at the initial process, at very initial when they sense that they become a little forgetful. And let me tell you, just by word of mouth, they are having excellent results. Therefore, people are out there paying from their pocket because the insurance won't cover, and they pay $80. I don't know how much is a month, and they are taking prevention, and they report that they are doing very well.
But not approved by the FDA.
Not approved by the FDA.
Okay. Anyone else have a question or a comment? Yeah, Karen, I have heard this response before, so I was not surprised. They do a lot of advertising on TV, that's for sure. If you have dialed in on your telephone and would like to make a comment or ask a question, you can press *6 on your phone and that will unmute your phone. Anyone else have a question or a comment? Well, while we're considering that, I think Marianne has some information on an upcoming festival, and we're going to pop up our survey. If you would take just a couple of minutes while we're here continuing our conversation to fill that out, we would appreciate it.
Good morning.
There's the survey, and there's Marianne.
Okay, hi, good morning. We wanted to take some time to invite you all to our face-to-face caregiver annual festival. It's going to be from 8:30 to 1:30 on August the 30th, and I'll put all the information in the chat. For those of you in the Corpus Christi viewing area, it's going to be in the Harvin Center at the Retama room upstairs. And then, as always, Dr. Praderio does the Walk for Memory. It's going to be November 2nd, and it's going to be at Water's Edge Park. And you can also go to our website. It's texasfacetoface.com, and you can get some more information on there. We'll be posting all the flyers and information on there. So thank you for joining us.
Thank you for sharing that information. Okay, we have a couple of minutes left. Anybody else have a question or a comment for Dr. Praderio? Well, I'll be back tomorrow with you if you have registered for the call tomorrow with Jess Ambley at noon. He's going to be talking about advanced directives and advanced care planning. We always encourage everyone who is a caregiver to make sure you have all those documents in place. It's incredibly important to do that. So I encourage you to come back with us tomorrow at noon and get your little checklist going and make sure you have everything in order. Yes, Mary put that on there about the face-to-face caregiver conference. Well, Dr. Praderio, nobody seems to have another question. Do you have any closing comments for our participants today?
No, like always, thank you for your to attendees, and to you, Glenda. Thank you very much for being very supportive. I wish you a good summer and looking forward to meet again.
Thank you so much, Dr. Praderio, and thank each and every one of you for joining us today and for all the work you do for the person you're caring for. I hope to see you on future sessions. Bye-bye.